So we'll move to the next talk. I would like to invite Dr. Samargandy from Saudi Arabia. Actually, we are very proud in the region to have a female interventional cardiologist, and not just a female, excellent interventionist in terms of coronaries and intervention structural. So Samar is going to talk to us about a new kid, Sondos, sorry. Sondos will talk to us about new kids on the block, general overview of the transcatheter treatment for tricuspid valve. So we welcome Sondos.
Thank you for the nice introduction. So just a hint that I'm starting at 12 minutes. So we're going to have an overview about the transcatheter, mainly treatment for the tricuspid regurgitation. So just a soft opening. We know that the clinical outcome of isolated tricuspid regurgitation is bad. And the more symptomatic you are and more severe you are, the worse your outcome. And mortality has been projected that to be almost reaching 48 to 50% at 1 year and or 4 years with severe symptomatic TR. So severe TR is a representative of a worse survival and more cardiovascular events. And that has also implemented in patients with post-TAVI and also patients who is going for post-mitral clip. This has been impacting it. Not only that, and also in surgical outcomes for patients who are going into replacement or repair in the mitral. So what we can see that concomitant TR in 1/3 of the patient who been going under TEER who had a moderate severe TR, yet only, like let's say 26.6% have persisted TR after the clip. And more than half of the patient post-TAVR, the TR remained unchanged at 30 days follow-up. So this is not a coincidental or like an innocent bystander. It's an independent predictor of mortality. And yet, do you think that we learned from that? Actually, the patients who have been offered treatment for this TR is in comparison to their prevalence is very, very small. And why is that? You can ask yourself, because it's been predicted or been exploited from the surgical outcome of tricuspid valve surgery, where we've seen that in-hospital mortality can reach from 8 to 10%, and mortality and morbidity in the long-term outcome may reach up to 20%. So where are we now? Due to the development and the success, what we're seeing in TAVI and in mitral clip, that we have opened, this is a mirror of opportunity, and now everyone is looking at the right side. Unfortunately, there are some uncertainties and inconsistency. Number one, we don't have a systemic approach when it comes to the assessment of the tricuspid valve. We have a confusing terminology on the anatomy, and we have challenges to determine the mechanism and the severity of the TR and its consequences in the right chambers. So, and this we're going to come shortly to it. So what is the objective? We're going to standardize the approach. We're going to talk about the state of the art, and we're going to have a main criteria for patient selection and what are the future uncertainties. So if you're going to have a picture, this is going to be the scope of the talk. The novel regurgitation classification, the novel nomenclature, and the novel imaging approach to tricuspid regurgitation. So this has been published for the last 1 year, that we used to think that it's called tricuspid, therefore it's just 3 leaflets, but actually we found more than 50% of the patients are having 3, 4, 5 leaflets. And you may say, well, so what? Well, it is reflecting in your strategical planning to counter this TR, and it might implement or affect or influence the outcome of your procedure. So they have integrated new classification, making it just like primary and secondary. We know that secondary TR is holding more than 90%. Just let's make it simple. Atrial TR, ventricle TR, or SED, or cardiac implanted electronic devices, and the primary. And you can see now they push the primary down in the scale. And you're looking, and when you're talking about atrial, it's annular dilatation, and you're talking about ventricle, you're talking about leaflet tethering. Let's simplify it more, because we are interventionists, we are visual people. Atrial functional TR, ventricle functional TR, and SED-related, and then the primary. And this is, again, we are visual people. This is when we talk about SED-related TR, like what is your pathology? Is it impinging? Is it perforating? Is it lacerating? Or is it just the good old annular dilatation causes? We expand the definition, and you can say, so what? We expanded the definition because now the definition of a successful TR intervention is decreasing the TR by more than 2 grades or 2 or more grades of TR. So if you have a torrential TR and you're still in the severe, you are successful, technically speaking. And now we're talking about multimodality imaging when it comes to evaluating the TR. Not only the echocardiographer, you have to look at the MRI, the function of the chambers, of the right chambers, what is going on with it, the right heart cath, the volume, the assessment. And this is implemented by the patient management and selection. And as you can see in the last column, we're talking about the diagnostic workup, and most of the European guidelines are pushing for right heart cath and evaluating the hemodynamics of the chambers, because this will implement the referral specialist, and this will implement your planning and to do or not to do the cases. And so why is it important? Now there's like the new kid on the block, which is the RVPA coupling, but it's in the crude number or crude description, it's representative of the RV contractility to the afterload. Simple as that, simple as it is. And how you give it, and it has a prognostic implementing factor, you just bring the TAPSE and you divide it over the PAS. And your numbers are usually 0.4. So this is one of the earliest papers that came to make it very simple for anyone who just doesn't know anything about it. Once you have a pulmonary hypertension going on, check your pulmonary vascular resistance. If it's in the borderline area, take the RVPA coupling. If it's 0.36 is too much for you, just say 0.4. If it's more than 0.4, go with it and fix it. So what about the patient? The more systemic burden that you have and symptoms on the patient, the less potential of improvement and the outcome of the patient. Therefore, go for patient early. Get them when they are still in the preserved ejection fraction. Get them in the child A classification liver problem. Take them with moderate impaired renal function. Still, they can walk around. They have some intermittency. Don't take patients who are in the end stage. Let's simplify it more. This is the TRI-score has been established, and it's basically talking about the same things that I just mentioned. Look at the age, the functional capacity, the diuresis, the GFR, and the bilirubin. And the more the risk or the score it is, the in-hospital mortality will increase. Unfortunately, I can say I had a patient who had a score of more than 9, and she didn't do well after it. So retrospectively speaking, I wished I listened to the clinician rather than interventionist inside of me. So what does the guidelines tell us? This is the American guidelines and European guidelines, and you can see when it comes to the downward, nothing is mentioned by the American guidelines when it comes to the transcatheter approaches for the tricuspid. And even the European guidelines is talking about 2B, C, which is like, consensus, and let's evaluate and let's think about it. So this is the science that told us what we can do, and this is the guidelines that told us what should we do, and now the registry will tell us what we're actually doing. So the TRIVAL registry is showing that more than 65% of the patients are going for edge-to-edge approximation. Of course, at the time of the presentation of this paper, it was mainly by off-label use of MitraClip. But for the last 2 years, after the trial study and CLASP study, we have now dedicated clips or edge-to-edge devices for tricuspid clip. And again, now we have a further insight when it comes to the RVPA coupling, and that's what we figured out a while ago, and its prognostic values. So pulmonary hypertension should be really looked, and right heart cath should be administered for all these patients when you make your decision. So these are the options that we have, orthotropic and heterotropic. We talked about leaflet approximation, which is the TriClip system and the Pascal ACE, and the annuloplasty, and then the valve replacement, which is still commercially not available. And then you have the heterotropic, which is the bicaval implantation. So let's make it simpler. So this is a proposed in terms of the algorithm where to go. As we can see, we are taking it from depicting it from the registry, 60% talking about that functional TR. So it tells you, go for the gap. What is your gap? What is your severity? What is the leaflet condition to decide where to go with your device? So we have the T, which is the TriClip system. They amended the mitral, they're a bit more flexible, more shorter to go and fix the tricuspid. And then we added a class to the toolbox, and which is the introduction of the ACE. And you can see it's a team effort. More than 15 people was involved in this case. Though it's a heavy slide, but if you want, you can take a picture of it, but it goes again with the same concept. Look at your leaflet, look at your gap, look at the etiology, look at your dynamics, RVPA coupling, and as you can, these are the ideal patients when it goes, especially in a startup center. You have to screen the patient. If you're gonna get out of it, just go for basic 2 images, RV outflow with X-plane and transgastric, because you have to understand the anatomy of the tricuspid, and we have demonstrated that in the beginning of this talk. And beside the first couple of steps, the rest of it is basically the same when it comes to the Pascal ACE or the tri-clip system. You have to nail your trajectory because it's very image dependency. And you have to understand where are you going and where you're going to clip it, because you have to have the same standardized talk. Am I going to go 1 to 7 o'clock, 2 to 8 o'clock, 3 to 9 o'clock, or where exactly? And why is that? Because you have to standardize your strategy. Am I going to go for tri-orifice or Clover technique, or I'm going to bicuspidize the vessel? And it's all about strategy, because when you go to the right side, it's the transgastric view. That's what we see, and the surgeon has different view. So you have to standardize your terminology, because if you can see in the left side, when you have a cleft between the antral and the septal, and you go, I'm going to just go from 2 to 7 or 1 to 7, you're going to open this valley, and then you're going to make the TR worse. So you have to strategize, and that's why the classification that I presented in the beginning is very crucial. And these are the outcomes that predict your improvement or, successful. We're going again, the coaptation gap, the tethering, the baseline TR severity, and your background of the patient and your RVPA coupling. When it goes to the orthotropic, these and heterotropic, as I said, we have currently the trick valve, which is commercially available, which is a heterotropic valve, and then the evoke and interpret that I'm going to focus more on it, but still commercially not available. What favors, to make it very simple, if it doesn't fit for the edge-to-edge, go for the valve replacement. And if the patient is very advanced, then you might consider the trick valve. So the evoke, what is advantage? It is a transfemoral approach, 29 French delivery system. And the interpret is still transfemoral, but it's a surgical cut down with a 35 French. And this is a quick demonstration of the evoke system. So usually what you get is introduction of the guide. And then you have the position of the delivery system, having a stiff wire in the RV. Then you adjust your coaxiality, basically, because coaxiality is all about it. And then you put your hooks, which is 9 hooks. We're going to be interacting with your cords for fixation. And this is you make sure of the positioning and the deployment of the valve. Have there been studies been done for that? Yes. And it showed a very good outcome in overall. And I think it's under CEA market registration, but it's been held for some logistic issues. We have the interpret system, which is basically the same, but it made it more simpler. And they advance across the tricuspid valve, they deploy the brim, they advance the desired position, and expand the fixation without involving the cord to make it more simpler. Still ongoing trial, and I think the one first case was presented in the TCT recently. What about the trick valve system? So usually you have both of them here. You have the severe TR, it's a transfemoral axis. The patient should be under anesthesia. Sorry. Can I have 1 minute only? For 2 minutes, that's it, and I'll finish. 2 is enough. Thank you. So basically, those for patients who are advanced cardiac disease that they have issues. And just to wrap up this, in post-procedure, and most of the patients, we know that they have anticoagulation pre-existing, so you continue with it. But when it comes to antiplatelet, we have been adapting from the mitral 1 month of DAP, then SAP with aspirin. It's advised that to keep the patient on diuretic for the first 3 months, to give the chance for the RV to remodel, and then have like a 1 to 6 to 12 months follow-up. Prophylaxis antibiotics should be administered, and SGL2 is one of the new kids on the block. Is though there's no like a standard trials, but is suggested to be introduced. We don't have solid data to correlate in surgical field, and the guidelines basically on the surgical outcome, and they are all based on the risk-benefit assessment. And procrastinate and withdrawing the intervention because it's deemed very too early or too late is our issue. So more patients have been ongoing under these transcatheter in advanced stages. They treat patients with belong with more, and it's too late, but that's what we say usually. And we have to look at that overall survival in patients with severe TR going for is higher than the patients who are going for medical therapy. We have to untreat severe concomitant TR does not predictably improve. And once severe RV dilatation has happened, you will have a bad outcome. We know that the heart team has a very important role, And just like with the final slide, it's important to question their remain. We need more randomized studies. We symptomatic and outcome of benefit of symptomatic TR correction compared to optimal medical treatment. We have to look for appropriate timing of intervention, and we have to look at what is our role when it comes to concomitant or staged transcatheter valve, and we have the comparative safety and efficacy of these established emerging transcatheter treatment, and avoid futile intervention. So are we changing the paradigm? We used to say, send the patient for complete fix, the aortic valve, repair the mitral, repair the tricuspid, but now are we saying, let's fix the TAVI, and then let's do the mitral clip, and let's do then the tricuspid clip, or change the valve. So these are, with this final remark, I thank you for your time, and I conclude my talk.
Thank you, Sondos. Thank you for this talk that is covering the forgetting valve, which shouldn't be anymore. So I think we have some comments. Yeah, Dr. Mohammed.
Thank you very much, Sondos. I think you did a great job. And first of all, I would like to say that we are very proud of our colleagues, ladies, interventional from Saudi Arabia. I think we started the business of mitral, for a long time. We started like in 2014. And when you compare the intervention, especially the clip or the Pascal and the tricuspid, it is a little bit different. You need a good echo. And even the echo, the views for the new people, it's difficult. The problem we have in the country, it's a late presentation of those people to us. There is some delay either from the clinic, from the admission, maybe from the patient themselves. And what we did see with the very limited experience so far with the tricuspid repair, with the TEER, that it's a very volume sensitive. It is related to the pulmonary pressure. And even that result you have immediately post-op or post-procedure, it could change on the second day. What is your comment on that? And I think the EVOQUE is very promising valve.
So multiple things to. So number one, in order for you to establish that, you have to have a good team to use, to stand on their shoulders. Otherwise, you won't be able. You have to have good imaging departments, and by that, not only echo, it also maybe MRI and also right heart cath, because this is where you start with your patient selection rather than having a futile case, successful technically, but futile case. But that's number one. Number two, in terms of the late referrals, so I'm going to take you from my experience. When I started in 2019, I was struggling to find patients. Either they are too far away or too early to actually just like having moderate severe TR and not they even on Lasix. But now, every month I'm having referrals because now you prove the concept. So people are changing their dynamic of thinking. So I'm expecting in the upcoming couple of years, people will be more and more interested and there'll be more sending patients. Nevertheless, we're talking about 90% is the functional TR. So control the heart rate, maybe the AF, convert them, maybe they will sinus. And I had patients who, once I convert them, the TR went away. I started an electro, the TR went away. I controlled their blood pressure, it went away. In terms of the volumetric assessment, there's like a couple of schools going with that. Your right heart cath will help you to know where are you standing. Your MRI can help you exactly what is the functional status of the RV. And therefore, you will manage the patient prior to the procedure. It is advised to optimize the patient as much as possible prior to going for the procedure. And don't drop the diuretics afterward. Keep it in. You might adjust it, but keep it at least for 3 months post and have a close follow-up for
Thanks,
the patient.
Sondos. We'll take 2 quick questions, please. First, Dr. Hani, and then Dr. Faisal.
Thank you very much. It's Hani Tiba, Glasgow, and it is really a very important topic, but also I'd like to zoom out from an interventional cardiologist to someone who's responsible for strategic planning of healthcare. When we started doing TAVIs, we had to compete and select for 5 million population, only 2 centers. And the number of cases that you're describing, and actually following the presentation following this, indicates that probably we need to start thinking very carefully about how we are going to implement these services. You cannot have sporadic centers that are doing a low volume. And at this moment in time, I think you should think nationally how we're going to do these cases, not just tricuspid. Same with mitral. The numbers are not anywhere near TAVI. The skills and the training is very, very important, and proficiency and participation in trial will require you to dedicate national centers to deliver these services, because as it has just been mentioned, volume drives proficiency, drives outcome. Thank you.
Thanks.
Dr. Faisal.
Great talk. Just a comment about futile versus validation. I think for this valve specifically, if you follow those patients in the clinic, really they are the patient that have the worst quality of life. So what's your thought if the technique improve with time, so as the cost? We offer TAVI for patients with 1 year survival or 2 year survival. I still believe tricuspid intervention, I couldn't agree more with Dr. Hani that should be centralized. But more importantly, we should look for different outcome than mortality. We truly should look at quality of life.
So, as I said, just commented that yes, we need specific centers. Not everyone should be doing it because it's mainly operator dependent, and there is a learning curve which has not yet been established. We don't know, maybe it's a 20 case, maybe 50 case. We're still the jury is out there. And what was your second question? Sorry, Dr. Faisal?
Given the procedure, we should not choose mortality in this specific valve as with our outcome, but I think quality of life, meaning you could still give the procedure for improvement in quality of life.
So the scope is not like the TAVI or, the left main revascularization. Is a bit different when it comes to the tricuspid, because the first symptom that usually patient comes with, I'm feeling fatigue. I'm not doing well. I have indigestion, this cardiac output situation. So your scope, basically, in the beginning, it's to improve the quality of life, leading to survival. But if there is a very excellent, successful outcome in terms of, whatever is the methodology that to prepare this tricuspid valve being successful, there will be an impact on mortality. And this has been demonstrated in the registries. So, for example, like in the tric valve, if the patient is every month in the hospital, he is not a surgical candidate nor an edge-to-edge repair, maybe tric valve, you just want to improve the quality of life in these patients. But nevertheless, don't take patients who are already on dialysis, who are already in class C or class D in liver failure, because you're not going to change even the quality of life, even if you're technically successful.
Okay. Last question. In 10 seconds.
Since the risk factors are really predictors of outcome, which patient should be sent for TriClip? What's your selection criteria?
So selection for criteria is like basically looking at the multi-organ failure symptoms and number one, symptoms of the patient and, the background. At least the patient should be viable and functioning to argue that the patient should go for a procedure. Number two, the pulmonary hypertension, and the more it's post-capillary, that it will help you more to fix it and go with it, and the absence of significant pulmonary hypertension at least. Number three, in terms of the kidneys and the liver, because these usually both organs have been affected. If you are up dialysis or approach dialysis already, or you're having esophageal varices and your liver is failing, even is not going to be successful, because already we're expecting that from the technical perspective, when you do the TEE, it's not going to be, the gap will be big, the tether of the leaflet. So your technicality might be even failing, or you will have suboptimal results. So I will steer away from multi-organ failure patients or bed-bound or non-viable patients as much as possible, on patients who have a very advanced pulmonary hypertension or pre-capillary element in them, as much as possible.
Sondos, thank you very much.
Thank you so much.
Thank you. Great talk. We need to see more and more of ladies interventional cardiologists in our next meetings. So this is your job to work on it beside the tricuspid valve.